Welcome to Fertility and Sterility on Air, the podcast where you can stay current on the latest global research in the field of reproductive medicine. This podcast brings you an overview of this month's journal, in-depth discussion with authors, and other special features. F&S On Air is brought to you by the Fertility and Sterility family of journals in conjunction with the American Society for Reproductive Medicine.
Hi, everyone, and welcome to another episode of F&S Unplugged. I'm your host, Pietro Bortoletto, and I'm joined as always by my three very esteemed co-hosts, Molly, Blake, Daylon. How are you guys?
Doing well, trying to trudge through all the craziness after this last week and all the Alabama situation, but staying good other than that.
We're doing fine, reeling from the recent news as well.
We're recording this episode on the Resolve Advocacy Day that's currently going on in Alabama in light of the recent Supreme Court decision in the state of Alabama. So our thoughts are with the people who are there on the ground, actively advocating for IVF access for patients in Alabama. And hoping by the time you listen to this podcast, something has been done to improve the situation for men and women needing fertility coverage in the state where the ASRM is headquartered. So really hoping that we see an evolution in the short term and on a local level, but also protections on a federal level for IVF. I know there's a bunch of smart people working on this issue. And today in the news, there was actually Tammy Duckworth, Senator Duckworth from Illinois, as I think reintroducing her federal IVF protections bill. So hoping we see more of that by the time we're recording this podcast next month. But for the time being, we have lots of other stuff to talk to you guys about. We have great literature coming out in our sister journals, and I never get to start, but I'm going to go first today. And the reason I'm going to go first is because this is actually a surgical paper. The reproductive surgeon in me got so excited to see something surgical coming out in our sister journals that I had to jump on the opportunity. This paper is entitled Fluoroscopic-guided hysteroscopic tubal cannulation, which is a really rad procedure that we just don't see a heck of a lot of. This paper is out of Brown University in Providence, Rhode Island, and senior author Maytal Sauerbund. And this is a cool paper. This is a technique that they have been using locally at the program at Women and Infants for some time. And it's a technique that they're finally kind of reporting on their experience and comparing it to a laparoscopic-guided hysteroscopic tubal cannulation procedure. So we know tubal disease is pretty common. Depending where you're practicing, a quarter to a third of our patients with female infertility will have some degree of tubal factor, and 10 to 25% of these cases are from proximal tubal disease. The first attempt at transcervical cannulation was first described in the late 70s, right around the time that we were kind of making headway with IVF. And there they were using selective salpingography, where you injected contrast media directly into the fallopian tube. This was kind of their first foray into can we identify proximal tubal occlusion? It was a decade later when Miles Navi introduced this transcervical cannulation into the proximal fallopian tube under hysteroscopic cannulation while watching with a laparoscope. And since then, people have been doing it all over the world where IVF has been limited or people haven't had access to it. And from the reported literature, patency rates are actually pretty darn good, as high as 90% in some series via the hysteroscopic approach. This group at Brown has published on this topic before. They published on their fluoroscopic guidance for hysteroscopic tubal cannulation, and they reported rates very similar, 90% successful cannulation rate and a 34% pregnancy rate without IVF. But this is kind of their first attempt to report on their contemporaneous single surgeon success rates for achieving tubal patency in patients trying to conceive with and without IVF, and comparing it to the more traditional laparoscopic approach, where you're doing this fluoroscopically with laparoscopic guidance. These patients were all women who were cared for at a single center in Rhode Island between 2015 and 2019 that all had proximal tubal occlusion and no underlying male factor diagnosis. And this was not a prospective study. This was not a randomized study. This is simply just kind of looking at their 4-year experience performing both versions of this procedure. So first, how did they diagnose tubal occlusion? So all these HSGs at Women and Infants were performed by an interventional radiologist. And if tubal occlusion was noted, then the interventional radiologist discussed performing selective salpingography, which is basically where they inserted a curved catheter, again without anesthesia, and attempted to isolate that single tube to see if they can confirm patency or can confirm occlusion. So if it failed or proximal occlusion was confirmed, they were offered a fluoroscopic-guided hysteroscopic tubal cannulation. But some patients had the laparoscopic tubal cannulation. And who are the patients who underwent that version of the procedure? Well, if they had a pre-existing indication for laparoscopy, pelvic pain, fibroids, endo, then they were going the laparoscopy route anyway. If there was a diagnosis of a unilateral hydrosalpinx that needed to be removed, if they tested positive for gonorrhea or chlamydia, knowing that that's a kind of positive predictor for tubal disease, these were all patients that were being shuttled towards the laparoscopic route. So interestingly, for the patients who got the hysteroscopic cannulation attempt, they all got IV propofol, and they all got an inhaled anesthetic agent. And the purpose there was for uterine relaxation. Something that if you think back to your obstetrics literature, remember like uterine inversion? How do you resolve a uterine inversion? You can use nitroglycerin, you can use inhaled halogenated anesthetics. Part of the reason why we don't use GA for C-sections willy-nilly, because it does cause uterine atony. So kind of a clever application of that anesthetic technique here for this procedure. And what they used was something called a Novi catheter. Again, Novi being the person who described it in the 80s. The Novi catheter was presumably named after him. So while they were undergoing hysteroscopy, they introduced this Novi catheter system through the hysteroscope, and then they brought in a C-arm and started to inject contrast dye in real time and kind of watching where the dye went. So if no dye was seen in the tube, then they presumed that there was tubal occlusion, and they then introduced a 3 French catheter with a 2 French inner guide wire and try to snake it through into the fallopian tube and make it kind of pass the intramural part and into the isthmic portion of the fallopian tube while they're having direct visualization. For patients who are undergoing the laparoscopic version of the procedure, they were essentially undergoing a chromoperturbation with a Clearview manipulator and methylene blue. And then the exact same steps were performed using the hysteroscopy. So the once the procedure was performed, these patients were followed for 6 months later. And in total, they followed 34 women who had undergone the hysteroscopic procedure, 42 women who had undergone the laparoscopic procedure. And really the big difference between the groups is that the ones who had hysteroscopy were a little bit older than the ones who had laparoscopy, 37 versus 35 years old, statistically significant and probably clinically meaningful. So once the HSG was performed and these either laparoscopic or hysteroscopic procedures were performed, in the laparoscopic group, 51% were found to have a true unilateral occlusion, whereas 81% in the hysteroscopy group were found to have a true unilateral occlusion. Importantly, of those patients who underwent the laparoscopy, 90% of them had some kind of underlying uterine pathology, whereas 97% had in the hysteroscopy group had an underlying uterine pathology. These were polyps, these were fibroids, these were scar tissue. There was a lot going on here. So it makes you wonder a little bit of, is this true proximal tubal occlusion, or is this kind of artifact? Is this a polyp that's sitting up by the ostia? Is this a fibroid in the cornea that's preventing fluid to get into that tube? There's a lot going on here. This isn't a clean, like free of uterine pathology group. Now, here's kind of the top line number. So in total, 91% of the patients who had a hysteroscopic attempt at tubal cannulation, they were able to successfully cannulate 1 tube. That number was 86% in the laparoscopic-guided group. Those are really high numbers. That's a really high rate of success for getting tubes open again. You're probably wondering, well, do they have a lot of perforations? How did that go? Perforation rate in the hysteroscopic group was 3%, and it was 7% in the laparoscopic group. So similar, not statistically different. That's pretty low for this kind of study. Now, yes, you got tubes open, but did it change anything? Did you get them more pregnant? Well, if you had a hysteroscopic procedure, 55% of those patients had a positive pregnancy test, which is amazing. And these are pregnancies achieved either with or without IVF. And for the laparoscopic group, that number was 64%. Not statistically different, both exceptionally high pregnancy rates, and really an amazing intervention for couples who may not otherwise want IVF, need IVF, or have access to IVF. And the next logical question you may have is like, how cost effective is this? Like, how much does this procedure cost? Well, these authors were nice enough to include it in the discussion section that the hysteroscopy, if you're self-paying at their institution, was $1,500. And if they did it with anesthesia, it was an additional $500. So pretty inexpensive intervention for patients with proximal tubal occlusion with a seemingly pretty high rate of success in cannulating tubes. And then after that, a pretty high rate of pregnancy with and without ART treatment. I really dug this study. Kind of the first thing that I thought is like, man, should I be doing proximal tubal recannulation here in Massachusetts? Difference with Massachusetts, of course, is we have a mandate and we have access. Patients have a large amount of access to ART treatment, so it can really overcome a lot of stuff. But not everyone needs IVF, right? If you can really open up a proximal tube and get patients back to conception the old-fashioned way, there's probably some benefit there from a patient perspective, a financial perspective, a societal perspective. So I really dug it. I actually plan on reaching out to Maytal, who's the senior author, who's a friend, and having her tell me a little bit more about it. But curious to hear from Molly, Blake, Dalen, heck, even you. What do you think about tubal recannulation? Have you done it before? Have you had much success with it?
Let me jump in and just say I don't know anything about cannulation, but for the folks at home, I'm watching these Zoom windows, and these guys are like up in the Zoom window, nodding with big eyes. So this must be a big deal. My only take is that, it underscores how clinical research and science is a living, dynamic entity. And it takes, trying things. And sometimes you try a thing and realize that it's just so much better. So I think it really makes me feel good about how the directions we're moving in clinical science in our field.
Yeah, shout out to Maytal, friend of mine as well, graduated the same year as I did. So it's always fun to see a familiar name in the authors and at the top of the paper, but hard study to do, honestly. I was just thinking about the last 3-4 years of practice, and I do these on occasion, but maybe, I don't know, a few a year at tops. And so not a whole lot of these come through. And we are a practice that, of course, we do a lot of IVF, but a lot of IUIs as well, because we don't have mandated insurance. And so, so we do a lot of IUIs before getting to IVF at our practice. But I was wondering if sometimes when you do these, you do an HSG and you see bilateral proximal occlusion, is it truly pathologic, or is it just the patient so uncomfortable from the procedure? And so maybe I skipped over it, but Pietro, did they try and do the HSG again before they did the surgery, or did they just go straight into it? So they didn't look at that. So
yeah, straight into it. There was a low single digit number of patients who the reason for the hysteroscopy or the reason for the laparoscopic procedure was just intolerance of the HSG. So
sure.
we're assuming there's something weird, and then we went to go look for it. But most patients tolerated the HSG fine.
Right. So it's probably unlikely a small percentage to have proximal occlusion from discomfort. But, that is something, of course, I wondered if you have the patient sedated and then you repeat the procedure, are the tubes going to be patent at that time? So, but by and large, reassuring study. Again, kudos to the authors. Difficult to look at this question.
Yeah.
Molly, do you guys do any of this in Oregon?
Yeah, we do some laparoscopically within our division. And then Miles Novi was at OHSU when he designed the Novi cannula. And then one of his co-authors on the original paper is actually a radiologist in the community. And so she'll do some fluoroscopic as well. So it's a great resource, but despite the fact that we do it, it's totally underutilized. And it's tough because sometimes a tubal factor patient is really young with great ovarian reserve. And I feel pretty confident that they can have a pretty good outcome with IVF and even just needing one cycle. And so it's hard to do a procedure or surgery that may have a lower success rate, and I won't be able to get them a baby quite as fast. But it's definitely something good to have as an option. With Blake, we may be overstating the success because maybe 30% of cases of proximal tubal occlusion are probably just uterine spasm.
And I forgot to mention, because I'm sure you guys are dying to know, but when these do come through, which again is not too often, I think I'm just thinking off the top of my head between myself and my partners, we may have just a handful per year. Really not a whole lot that come through that we do, but we do them fluoroscopically in our clinic with a Janssen Anderson catheter. I've done them a couple of times laparoscopically in the last year, but we usually just give the patient Valium, had about an hour beforehand, and they tolerate it quite well, actually. But we do these for the majority of the time via Janssen Anderson catheter under fluoroscopy in our clinic.
I think a lot of it depends on kind of who your personnel is, right? So at Cornell, where I did fellowship, the physicians did their HSGs in the procedure room in the hospital, and that was always kind of a heavy lift. And the hycoses were also performed by physicians, but now on the clinical side, where you're already seeing patients at Boston AVF, we have nurse practitioners and PAs who are performing our HSGs and our hycoses. So I feel a little bit more removed from tubal evaluation and uterine evaluation. And I think if you're thinking about, like, I really dug the idea of having a selective cannulation performed by the IR doctor at the time of the HSG if they diagnose proximal tubal spasm. I was like, man, it'd be great to teach nurse practitioners and PAs how to do that. All right. Well, thanks for letting me rant about a surgical study. It's always nice to see stuff that's surgery minded in F&S and our family of journals. All right, let's keep moving and let's make our way back to some real science, the clinical stuff, the basic science stuff. Dalen, tell us what you have from F&S Science this month.
First of all, it's all real science, Pietro. Watch your tongue. But I'm moving from the, interventions to the etiology here, talking about something that's really in the news, and I'll come back to that. But let me start just by stating what is generally accepted. I would say outside some controversial fringe opinions, the overwhelming consensus is that the number of oocyte-bearing follicles in the ovaries is finite, non-renewable, declines inexorably until menopause and midlife. We all know this, but for those uneducated, that's the consensus, guys. And an accelerated rate of decline is thought to be one of the byproducts of increased environmental exposure, specifically to phthalates and other endocrine disrupting chemicals used in the production of plastics. But concrete links between cause and effect of these chemicals and reproductive disorders are difficult to discern, particularly in, a genetically diverse population of humans living their lives across a broad range of environmental exposure levels. But I think we pretty clearly now recognize the ubiquity of plastics, even at the nanoscale, in every conceivable setting, contaminating virtually everything we consume. Just today, Guardian headline, microplastics found in every placenta tested. Pretty disturbing. Science even has elucidated mechanistic links between endocrine disrupting compounds and plastics and downstream pathological influences, particularly as it relates to the reproductive system. And the public is pretty well educated as to the health risk, even if that risk isn't really clearly delineated or understood. And you look at, if you guys have kids, you look at your kid's school, there's nary a plastic water bottle in sight, and silicone is the new Tupperware. But exposure to phthalates is really impossible, I would say, to mitigate. And their prevalence, disturbingly, has coincided with a significant increase in reproductive pathologies. We talk every day about declining sperm counts, decade over decade, increased infertility across all developed nations that we look at. If it isn't already a part of the infertility consult, I don't know, maybe it should be. So I'll put it to you. Do your guys' patients bring up or ask about plastics, phthalates, or other endocrine disruption with you in their consults?
I've never been asked by a patient who's I'm seeing for infertility, because I think they're just so focused on, I just want to get pregnant. But I have lots of obstetricians, and the obstetrician who delivered both of our kids told us very openly about it at the beginning of pregnancy. Like, hey, there's a couple of easy chip shot behavioral things that we could be doing to mitigate exposure. And do you microwave stuff in plastic in your microwave? Can I convince you to buy some glass Pyrex that you can use during the next 9 months? Can we switch you from water bottles to aluminum water bottles? So we kind of heard that in pregnancy and made some real changes that we've kind of stuck with for the very, very long time. But no, it doesn't come up at an infertility consult with me, at least not yet, but maybe we should.
Yeah, well, it makes sense to me because, obviously, with the recognition of teratogens and how precious and, vulnerable the fetus is during those developmental stages, especially neurodevelopment, it's a no-brainer, right? No pun intended. But maybe we need to move that logic into the reproductive space. Maybe that's having an effect not just on our reproductive capacity, but our health generally. And I think that's where momentum is kind of moving. I wouldn't say consensus, but a lot of curiosity and concern. And while we may intuit the link between plastics and reproductive biology, it's pretty tough to gather strong evidence toward that conclusion. So there's still a lot of naysayers. And the sad reality and scary reality is that there's just so many compounds to look at. And they're so ubiquitous that it's difficult and or unethical to conduct controlled experiments. Unlike in Europe, in the US, you have to prove something is bad before you take it off the market in the US. In Europe, you got to prove something is safe before you get it into the market. So there's all these compounds floating away that are in all likelihood a major liability. And we've only, we haven't done enough to get them off the market. See BPA, which is now BPS, which is also probably not safe. Anyway, getting back to our experimental approach, the best you can do right now in terms of causation or establishing some element of causation is animal models, which are not a great proxy. I'm loath to even mention mice to you guys to see you roll your eyes. But even larger animal models that approximate human folliculogenesis are really cumbersome and limiting in other ways, not least of which is expense. But defining correlations, on the other hand, between phthalate levels and reproductive parameters, that's a really critical prerequisite, I would say, to guiding our thinking on which compounds among the broad range of phthalate subtypes pose the greatest risk and how they might mediate their pathologic influence. There's a lot we can do with modeling or using those compounds in animal models, which once we have targets. So we really got to establish that correlation. And to that end, Firuza and Rajesh Parikh at the Jaslock Hospital and Research Center in Mumbai, India, whom we've actually talked about on the show about a year and a half ago. They had this COVID study here. They led a new study of endocrine disrupting chemicals in IVF patients, here performing a sub-analysis of a prospective cohort study of IVF ICSI patients. And here they correlated the levels of 6 phthalates that they looked at. The names, I can't even say them, so just look at the paper. But these 6 specific phthalates among the dozens that are out there in common use. And they correlated those, in the follicular fluid, they measured them, of those patients and correlated them in 245 women, correlated them with their antral follicle count, serum AMH, peak E2, total number of oocytes, and mature oocytes, of course, adjusting for maternal age of BMI. And they found what they were looking for, a link between increased levels of some of those 6 phthalates measured and reduced parameters. And you can see for yourself on the details there. I'll say it, the results weren't overwhelmingly stark, but we've got to put things in context here. We've got no window into the duration or level of exposure, not to mention the broad genetic differences in ovarian endowment and or capacity to metabolize phthalates. I mean, that can vary considerably. As we know, we haven't accounted for different types of environmental insult that these patients may or may not have undergone in their lives, or measured all those other phthalate subtypes, as I said, of which there are dozens. We get this one snapshot of patient follicular fluid on that day and their reproductive parameters. So it's not a lot to go on, but there's still a difference that was noted. And I'd like you guys to keep in mind, and listeners as well, we need these studies to provide the rationale for the long, careful, and resource-intensive studies, most likely in non-human primates, that are going to approximate our own biology. And I'm willing to bet that those studies are already underway and are going to take years, maybe even decades, to come to a real concrete conclusion. But hopefully, this type of study is an entry point toward finally cracking that nut. What do you guys think?
Dalen, has this ship sailed? Are we just so neck deep in phthalates and BPA that we're like, it's a losing battle? And I hate to be a Debbie Downer, but kind of like climate change, right? Have we gone past the point of no return where it's like, you know what, accept it. This is our fate. What do you think? Am I being too negative about this?
You're being pragmatic as always, Pietro, and that's what I appreciate about you. And I will say, yeah, we're getting really good at curing cancer. So we'll probably sew that up when those endocrine disruptors come back to haunt us. So ART is doing its job. You guys are tremendously successful. But I would be worried about the unknown unknowns. I mean, the problem is all these synthetic compounds that are ubiquitous in our environment are having an effect collectively. And I think that's the real challenge. And they're having an effect across the board on our health and quality of life. So while, yeah, we can come up with solutions, I think that we're kind of bailing water out of a sinking ship. Maybe it's just it's a matter of how quick the water is coming on before we can get rid of it.
Kind of scary to see these results, right? I mean, it does make you wonder, what are my levels if I had follicular fluid? But obviously, this is a relatively small sample size and it's not generalizable. It's specifically in India, but it does make you wonder, what does it look like for all women in our practice? And even in women who do their absolute hardest to not use any plastics, don't heat up anything in the microwave that's plastic, what would their levels look like too? And does it even make a difference? So raises a lot of questions for sure, but it's kind of scary to see that they're finding this, and there very well could be a correlation. So certainly prompts a lot of thought.
Yeah, and one of the great ironies I would point toward is that what is a major source of phthalates and endocrine disrupting chemicals? Medical devices, all the tubing, right? So,
Yeah.
you know, we do our best, but sometimes we're part of the problem. The question is how great of a problem, back to your point, Pietro, what's the scope of the problem? And I think that's what we really got to get our arms around. So, Blake, it's scary, but let's not overreact.
And then just from a mechanistic perspective, do we know much about, is follicular fluid a place where you just concentrate phthalates? Is it like a sink where things end up in higher concentrations, but like
Right.
in the placenta, in the uterus, and kind of more biologically important parts of reproduction, does it show
Yeah.
up? Is the placenta as good of a filter for all that stuff as well as we think it is? Like that to me is, I think, the unknown from a maternal fetal transmission. Certainly there's impact for the mom carrying the pregnancy who's got the excess phthalate exposure, but in pregnancy, is the placenta protecting us? Leave it in the follicular fluid. It's probably better there.
Or what about in our tubing that we do egg retrievals in? The fluid goes into those little plastic tubes and it's being heated up in a little incubator. So is that causing phthalates to be released? I don't know.
I was just going to say, Blake, this is follicular fluid that's pooled from all the retrievals. So I don't know, maybe you could consider a logic where you have a lower antral follicle count. Maybe there's less passages through the tubing if you're using the same tube. I don't know. There's crazy interpretations where you got to consider these results in context. And that's why we need, absent some horrific human experimentation program, we need some large animal models to do real A/B testing. And as I said, I hope and believe that those are forthcoming.
I do love these follicular fluid studies because it's like one man's trash is another man's treasure, or woman's trash, woman's treasure. But I agree. Yeah, association, not causation. But I think we should all be pretty concerned about phthalates. There's a huge, huge body of evidence on phthalates in reproduction, and the really concerning things is that it's affecting women more than men. Higher concentrations of phthalates for women than for men, maybe related to beauty products, personal care products, and then higher concentrations in Black populations as well. So there's certain groups that are more negatively affected by this. I'm not Gen Z, but sometimes I like to watch TikTok, and there's all these videos of people doing these like 12-step skincare routine, and I'm just cringing. I'm like, each step you're putting more endocrine disrupting chemicals on your face. Like, just stop at one step. So I think the younger generation will definitely be affected too, unfortunately. But definitely, yeah, agree. More big animals, large animal model research is needed.
For the record, I started using a nightly moisturizer 6 months ago for the first time in my adult life. So
I can tell you've got a glisten to you. So
thank you. That's
yeah. I was actually about to ask that question.
Yeah.
You're glowing, but your phthalate level's a little bit higher than it was.
No.
Yeah.
Take the good with that.
YOLO.
Well, Dalen, thanks for scaring the bejesus out of all of us and making me want to drink out of aluminum cans from a stream only. Horrifying. Thank you.
Watch out for the Giardia, buddy.
Had it once in Ecuador. Don't recommend it. Better than Ozempic, though. All right, Blake. Let's move on to F&S reviews. What are you reviewing for us this month?
We're talking about side effects of Ozempic in patients infected with Giardia. No, I'm just kidding. So this is a systematic review of epigenetics of a diagnosis we all know, endometriosis. First author, Dr. Bedrick, and senior author, Dr. Singh, out of Johns Hopkins in Baltimore, Maryland. As we know, endometriosis is very common, very, very common. We see it all the time in our practice. It's a very unfortunate disease, and I hate to see patients with it. I always tell patients it's a straw that no one should be dealt. And it is one of the leading causes of gynecologic hospitalizations in the US. It's estimated that direct and indirect healthcare costs are estimated to be over $12,000 per patient per year. While most commonly proposed theories of endometriosis are ones that we well know: retrograde menstruation, coelomic metaplasia, vascular or lymphatic dissemination, embryonic cell rest, the role of epigenetics has emerged as a promising contributor, which is where this new study comes in. Epigenetics are inheritable. They are alterations to genetic expression that don't affect the genome itself. So these epigenetics involves the modulation of the expression of a genotype through DNA methylation, histone modification, and non-coding RNA, which we'll talk about. So these modulations can alter the physical structure of DNA and can play a pivotal role in cellular differentiation and might even silence or activate key genes at the cellular or the organism level. So these alterations in gene expressions in endometriotic tissue can have direct implications on cell cycle growth, cell cycle arrest, apoptosis, and because of this, may play a key role in the pathogenesis of endometriosis. So the authors looked at this by doing a systematic review of over 18,000 studies. Ultimately, 57 were included in the analysis. Several studies evaluated the level of methylation of specific genes when comparing endometrial biopsies to patients that have normal tissue or without endometriosis. So what did they find? Of the 57 studies included, there were about 1,600 patients with endometriosis. About 1,200 were controls. Looking at the background of these patients, about 60% were Asian, 25% were American, 14% were European, and 2% were from Africa. They found that acetylation and methylation were the two main key histone modifications that were centered in this review. There was an association between modulation of several different genes and endometriosis. There's a lot of baggage to unpack, a lot of which needs further investigation. So I'm going to provide a brief, succinct overview of the gene modifications that they had found. And as always, I encourage the listeners to go back and read the paper in its full detail. So the genes involved in hormone regulation that were studied, including steroidogenic factor 1 or SF1 that we know as RAIs. This regulates, or one of its roles is regulating aromatase. SF1 levels were found to be significantly methylated in patients who had ovarian endometriomas. Additionally, they found that there were several studies that identified an association between endometriosis and hypermethylated genes, including ones that we probably haven't heard of before, PGR. This is one of the progesterone receptors, SF1, and then RAS-F1A. They looked at other genes such as HOX genes, COX genes, interleukins. These were found to be hypomethylated in endometriotic tissue by several studies. And then in regards to histone modification, there were several studies that reported acetylation levels of histones H3 and H4 affect multiple genes associated with endometriosis. Now they looked at hypermethylation of tumor suppressor genes and hypomethylation of oncogenes, and these were found to be associated with endo. They found a few other genes that involved hypermethylation of steroid hormone regulating genes, some of which were progesterone receptors, some of which were estrogen receptors. And then lastly, they found that alterations in DNA methylation and histone modification often occur in the same gene and tissue from endometriosis patients. So again, this is a lot of information on a ton of genes that I just very, very succinctly had packed into their findings there. But what did they conclude from this? So the results were very wide-ranging. There were several key similarities that did emerge, though. There were several studies that repeatedly found that hypermethylation in the promoter region of tumor suppressor genes and hypomethylation in promoter genes of oncogenes were associated with endometriosis. Despite extensive research on DNA methylation and endometriosis, there still remains some disagreement among the results. As I went through this paper, I found that there were several times where they would say a study found hypermethylation of a certain gene, and then they'd say, but this study found hypomethylation, or maybe no difference. So nonetheless, this review covers a very wide range of different genes, many of which have conflicting findings, very likely due to the heterogeneity between these studies. But these findings offer insight into the role of potential biomarkers and treatment targets for endometriosis, because that would be the holy grail, right? If you find a gene that we can just simply test and we can treat and find patients that have endometriosis without doing laparoscopy or doing surgery. So the list goes on, but it would be the holy grail to be able to find these tests. So what do you guys think? I know there's a lot of these tests, these not very well studied tests you have patients ask about all the time, and they test for what type of bacteria is in your colon and maybe your uterus. And also it looks like you've got endo from this test. And also maybe we need to add more progesterone from this test. So not a lot of data in these studies, but what do you guys think about this?
I think this totally lines up with what we see clinically, right? Endometriosis is an umbrella term for a pretty wide-ranging disease. And I'm lumping endometriosis and adenomyosis. I think fundamentally there are different spectrums of this exact same disease process, but I think you see it. Not every patient with endo has pain, although most do. Not every patient with endo has infertility. A lot of them do. And not every endo patient responds to kind of the bread and butter of therapy, OCPs, aromatase inhibitors, surgery. I think it's because it's a pretty individual disease. And I think that's why you see some of these conflicting results. I think we're not doing an awesome job carefully phenotyping endometriosis yet. I think we smack a label of endometriosis and say whether or not it's ovarian or not, or whether or not it's deep infiltrating or not. But I think that's like a 50,000 foot view. I think we're hopefully getting into the era where we biopsy lesions at the time of excision surgery and get a pretty personalized sense of like, oh, this patient has this kind of endometriosis that we know will respond to this kind of treatment optimally. And that's, I think, how we really move the ball for endometriosis treatment from a pain perspective, but also hopefully from a fertility perspective. So I'm not surprised by these findings at all.
My comment, and I want to start by saying this is really tough. It's a really tough problem. And to your point, Pietro, it's not monolithic. It's a whole constellation. So we're looking at a lot of different things and trying to define the single etiology is like the holy grail, I guess, if you want to call it, because that's what we want, a silver bullet. But that's, I think, a little bit overambitious. And I think we need to reframe our entire thinking. And you guys, I know you secretly hate me for saying stuff like this, but I'm going to say it again. We need a model. We need a better model. And I'm not talking about like mice, right? I get it. That's not going to work either. But it stems from my one, I guess, concern about the approach, which is when you're looking at a lesion versus what? You know, if it's a lesion, that's like a different organism than utopic endometrium. We need to see the endometrium right when it's about to make its transit. You know, we need to understand the transition and what the gene activity is then. By the time it's over an ectopic site, there's all kinds of stuff going on. There's all kinds of cells, there's all kinds of pathways, inflammatory, that are all then consolidated into a single profile that is like a Frankensteinian view. You know what I mean? We're not seeing the etiology. We're seeing all the different, sequelae, cellular sequelae across all those different cell types, and then we're collapsing it into this 2D overlay. It just doesn't work. I think we need to come up with a better model, or we need to take the endometrium out of the body and use an ex vivo platform where we bombard it with some, logically driven targets and see what recapitulates some of the pathology, and then put that endometrium into an animal and see that it recapitulates some of the invasive or inflammatory aspects. Like, I think we need to start over, which is not to denigrate or throw shade on this review. I mean, this is all the studies that are out there, but I think we need to start from zero now. And one of my major conclusions from this review is that a lot of the data out there is, of course, going to be conflicting because we're looking down the barrel of a gun here. I don't know what that a metaphor is and what it means, but hopefully no one's going to die at the end.
Dalen, to your point, I met with a company recently. There was this symposium in Boston called the Reproductive Health Innovation Summit. And it was a group of early stage founders and people that are trying to innovate in, broadly speaking, reproductive medicine space. And there was a group from Texas that was using organoids as a way of studying. They were collecting endometrial biopsy samples from women with recurrent implantation failure and developing a model in the lab for the endometrium. And then they were creating a blastocyst organoid to be able to dynamically evaluate what does that endometrium do when we expose it to blastocysts, an infinite number of blastocysts that we have at our disposal. And can we dynamically test progesterone doses and concentrations, immune modulating therapy, any number of things that you think may be impacting the endometrium? Can we use a model to be able to really sort it out on a patient by patient basis? And I was like, man, that is the way to answer these questions. This like one size fits all shotgun approach, like everyone needs this treatment, is like so not nuanced. They don't do it for cancer anymore, right? Like cancers are subtyped based on their receptor status, their likelihood to respond to this treatment versus that treatment. We still don't have any of that in reproductive medicine. We have so little of that. And the issue here is this is not a big enough moneymaker for people who are trying to innovate. Everyone's innovating in cancer. Money is in cancer. It's a much bigger market to innovate in cancer. And I think, unfortunately, we're going to be lagging behind until people have more access to IVF and we actually treat all the patients who need infertility care. And then the market gets big and then people want to innovate in this space. So we're kind of a little bit stuck in that lurch right now. But I think you're thinking about this the exact right way. We need to be moving towards models to be able to personalize some of our recommendations and our treatments.
Yes, and just quick follow-up. Technically, we're there. You can now get these endometrial organoids from menstrual fluid. So it's non-invasive. We can do that for every patient. And yeah, I think, again, to your point, the problem is that for a lot of people, reproductive health is not life or death. But I mean, we who are closer know that it's life or no life, as some very wise person told me one time.
All right. Well, Molly, you got to bring us home. Hopefully you have something lighthearted and easy read from Consider This month.
Oh, yes, super lighthearted. I think we're all feeling lighthearted. So my Consider This piece I chose today is called The Fate of Supernumerary. I had to look that up. I thought the word was supernumerary. It's supernumerary cryopreserved embryos, out of sight but not out of mind, by lead authors Valeria Pritkova and last author Stephen Lindheim. So I chose this piece because I thought it was relevant, unfortunately, in light of this recent really upsetting ruling in Alabama and the awful ripple effect we've seen in which multiple clinics in Alabama have had to stop IVF care and really prevented family building for hundreds and thousands of people. So the authors initially present a descriptive study that they did within their own clinic on embryo disposition directives, and they raised some discussions regarding the findings. But in their introduction, they review that as is standard for the IVF consent process, patients are asked about the disposition of embryos in the event of death of one or both partners or dissolution of the couple. And options are transition to one partner, research, embryo donation, or discard. But despite the directives in these contracts, when the storage agreement is close to expiration, most programs will still recontact the patient or the patients and confirm the directive. This creates a real challenge for IVF practices, though, because patients can be lost to contact, and that occurs in about 5 to 7% of cases. And sometimes it's on purpose, and sometimes it's just that their address or their phone number's changed. We can't reach them despite our best efforts. So I think this can partially be prevented through very explicit consenting that really details what will happen in the case of loss of contact. But another issue is that a lot of patients seem to change their mind, and that's really highlighted by this Consider This piece. So one study asked 41 couples who had embryos stored for more than 3 years what disposition they would want, and they found that actually 71% changed initial preferences, and 59% of couples who wanted to initially dispose embryos then chose to either continue in storage or donate embryos, and 82% of those that wanted donation no longer wanted that. Another study found 59% of patients changed their initial directives, and that almost half of patients did feel that they weren't adequately educated on their embryo dispo options. And so there's been a lot of recent efforts to improve education, improve consenting around embryo disposition. It appears to be pretty well received so far. More work is needed, but I think part of the issue is that even with the best education, the best counseling, the best consenting, people are going to change their mind, that there's this moral value or meaning that they may ascribe to an embryo that could change throughout the course of their treatment, throughout the course of their life. So the authors for this particular piece looked at 104 patients who had autologous IVF at their institution, and it's a descriptive study of patients' embryo disposition directives. Some of the interesting findings were that in the event of death of a partner, a really high percentage, 76.9%, would want to give the embryos to the surviving partner, but in the event of a dissolution of a relationship, 0% would. I think that's what you might expect, but it's still interesting to see this stark contrast in numbers. They also compared disposition directives for, of the 104 patients, 52 couples who then had a second IVF cycle, and whether dispositions changed over that short course of time. And they found that 38.5% had some sort of change, and 30% had 3 or more changes to their disposition directives. And notably, 2 of the couples said that they changed their decision based on the recent Dobbs decision, but the authors didn't highlight more which way they went and how that decision changed. So In conclusion, there's a lot of changes for individuals or couples in embryo disposition directives, and it's not just happening 3, 5, 10, 20 years down the line. It might even be occurring from back-to-back IVF cycles that these values are changing and these goals are changing. The authors do argue that each time decisions are changed, we should really readdress this. And I wonder how many patients after that conversation might retroactively want to change the directives for a prior cycle, and how easily that's done within a clinic. It really, as I said, highlights how fluid patients' views on their embryos are and how their own backgrounds, their experiences, and then this acute experience of having gone through their first IVF cycle, getting ready for their second IVF cycle, can just change their perspective in real time. And in light of really recent national events, these discussions have become even more important. So this whole conversation is really challenging for clinics. Storing embryos, as we all know, is super resource intensive, has a lot of liability for practice. But now at practices in Alabama, even if you have a really explicit verbal and written and everything directive to dispose of embryos, they can't because of serious legal consequences. So it's a lot of topics covered, but what do you guys think? What do you think of this article and what's going on?
I think the IVF naive patient just doesn't know what they don't know. I think the longer you're in the game, the longer you're in patient mode, you learn stuff along the way. Of course, you wish you knew it sooner, but there's an experiential part, I think, to being an IVF patient. You finally understand the difference between an egg and an embryo. You finally understand the difference between an embryo on day 1 and an embryo that makes it to day 5 or day 6. So I'm not surprised that people's opinions evolve. They evolve in pretty dramatic ways. But I think a lot changes once you find success with IVF the first time. And now you're faced with these embryos that you thought were just like, hopefully, two-celled organisms living in a freezer, not unborn children. But you can totally see how people's perception evolves on what they would want to do with them after they've achieved success with them, and vice versa.
And I think after just all the craziness that's happened in Alabama, and again, we've known that this was going to happen eventually with IVF, but now that it's happening and the way that it happened with this lawsuit in Alabama is just so unfortunate. But I think that people are going to be much more cognizant of this moving forward, knowing when they're signing embryo disposition paperwork, but also you mentioned people's minds change over time, but they may be forced at this point to transfer all their embryos, for example, if they don't even want to, or can you even, if you do PGT, which, in the future, can we even do PGT? There's so much uncertainty at this point, but if you do PGT, you have an aneuploid embryo, do you have to transfer that? I mean, there's just so much uncertainty at this point, and people may be forced to utilize those embryos in ways that they would not have before all of this has happened, after Roe versus Wade was overturned, after this lawsuit in Alabama. So there's a lot of uncertainty with regards to what will happen in the future with embryo disposition. So heavy topic, timely topic, but these are unfortunately things that we all are having to really think about now, and our patients are really having to think about now too. So
yeah, I think it's notable that the direction of the change was not monitored or wasn't reported. I mean, because listening to Petra, I think you're I don't know whether that's an optimistic view. You're probably right, and I would defer to you. You're close to these patients. I think you understand their sensibility, but I wonder how close it was. How many of these patients went to a more conservative disposition based on what they were seeing politically in this, borderline theocracy? I caught Eve Feinberg, our friend, on Sanjay Gupta today, and she said something that really stuck with me in terms of just how ambivalent even REIs are about this. When you speak legally, in terms of legal terms in the context of divorce or whatever, embryos, disposition, they're defined as property. And what she said there that really stuck with me is, I think that's, I don't know what word she used, but it's, I guess I'm paraphrasing, insensitive, or it deserves consideration. I think that we are trying to classify these things in such stark terms to make them easier. But they're not easy. They're really complex. And part of the challenge is that we want hard answers. The great irony to me is that this one political position is that a thing can be property, but also be a baby. And I haven't heard that view since pre-Civil War. from these same people. So I think it's illustrates how ludicrous some of the political positions surrounding these are and threadbare, and how we got to see through those and get the education to the patients who are really going to be affected by these.
I'll leave you guys with a fun upcoming event that I'm hoping to share a little bit more about our next podcast recording. I gave an interview to the Boston Globe recently regarding these changes in Alabama, and one of our local congresswomen was moved by the story. She's an IVF mom herself, and she has invited me to join her at the State of the Union on March 7th in Washington, D.C. as her guest, to raise this issue on a federal level, that we need federal protections for IVF, and this is important. And so I'm going to be heading down to Washington, D.C. next week to join her, hopefully talking to lots of local and national media about the topic and raising awareness, but hoping to have something positive come out of it and share it with all of you this very next podcast recording. So stay tuned.
That's really cool. Congratulations, Pietro. And that's really an honor, too. That'll be really exciting to hear what comes of that. And then tomorrow, too, I know our listeners are going to be hearing this well after this occurs, but tomorrow there's going to be a lot of people at the Alabama State House doing a lot of advocacy. And so our hearts go out to all of them, and we hope that some politicians' minds change and we have some positive direction with all of this that we're trying to crawl out from after last week.
Well said. Well, until we meet again next month, take care. That's all we have for this month. Bye-bye.
This concludes our episode of Fertility and Sterility on Air, brought to you by Fertility and Sterility in conjunction with the American Society for Reproductive Medicine. This podcast is produced by Dr. Molly Cornfield and Dr. Adriana Wong. This podcast was developed by Fertility and Sterility and the American Society for Reproductive Medicine as an educational resource and service to its members and other practicing clinicians. While the podcast reflects the views of the authors and the hosts, it is not intended to be the only approved standard of practice or to direct an exclusive course of treatment. The opinions expressed are those of the discussants and do not reflect Fertility and Sterility or the American Society for Reproductive Medicine.